My name is Sid Gerber. I'm president and owner of Personal Caregiving Services. We are licensed as a non-medical home health agency in the Houston, Texas market. I've been in long-term care for 33 years now. I started out as a nursing home administrator for 8 years. Before that, I was in a totally different business, but really wanted to get into the healthcare administration focus. So I had sold my business that was a family business in 1989, went to the University of Texas Health Science Center, was actually, because I couldn't get into hospital administration, I asked a longtime high school friend of mine who is a long-term care administrator himself, what what opportunities there were for me. He suggested that I get my long-term care administrator license, and I did that through the University of Texas Health Science Center here in Houston. I was thrown into a class of 35 graduate nurses who were also taking the long-term care administrative curriculum. Completed that in 1992, and my first building was, after 2 weeks, the current administrator of that building, which was a 200-bed Medicaid facility here in Houston, said, "I'm leaving for another job in Dallas, and you can have this if you want it." So I went ahead and stayed with that building for about 4 years, and then left to go to two other facilities. My last facility was in 1996. I was at the groundbreaking ceremony for exclusively an Alzheimer's and dementia facility, skilled nursing facility, and took it out of the ground and stayed with them for another basically 3.5 years, and left in 2000 to really, it was at that point in time, I, of course, worked in for-profit corporations. And the key for them was filling the building and census. I had a weekly census meeting every week. And the first question was, "What's your census today? And what are you going to do about increasing it?" And so it's not what I signed up for. I decided to leave and go out on my own and became a geriatric care manager, consulting with family members, adult family members, and spouses who had mostly elderly that needed some guidance and education and coordination of care. So I did that, oh gosh, from 2000 to about 2009. I had my own business in consulting and doing that. And then some of my private clients would ask me to help manage their private caregivers. And I suddenly realized that because they were not my employees, they weren't going to do what I asked them to do, and trying to improve the quality of care and life of the clients I was consulting with. So I realized at that time I might as well jump into it and become licensed with the Texas Department of Health and Human Services. In 2009, I started my own non-medical agency, and that's where I am today. I have approximately 80 caregivers in my pool. Most of my caregivers are trained in Alzheimer's and dementia care because the predominant focus on my services are dealing with clients who have Alzheimer's and dementia. And that's my story.
That's a great story. All right. Well, let's talk to Maddie. Maddie, tell us about your history.
My name is Maddie Bunch. I'm a nurse case manager, the BSN. I went to college at the University of Bridgeport in Connecticut and did my clinicals at Yale New Haven and Bridgeport Hospital. I decided, after meeting an orthopedic surgeon in New York one day, after he said to me if I was interested in a job, call him and go to Texas, I packed up and moved to Texas and went to work at the Institute for Rehabilitation and Research. My first role was the 11 to 7 shift in the ICU of peds and adults. And there I was, the only RN, and it was my first night at work. I went, "Oh, this went well. This will go well." But anyway, it turned out great. I had a long career with TIER and moved from TIER to the VA hospital in Houston, where I worked in the brain injury and spinal cord injury as a nurse manager, and returned to TIER under a federal grant to establish case management in the community, and then was moved up to nurse manager of their outpatient clinic. And when I was in the outpatient clinic, I would see the nurses come in. At that time, insurance companies had nurses, registered nurses for workers' comp. And I was watching and I thought, there's more to this service than just the workers' comp market. And in 1984, I left here and started a company with another woman. She was an occupational therapist. And we had the company for 13 years. Our focus was catastrophic injuries, and we subsequently sold it. And when I left that company, I started M. Bunch and Company, which is my existing company now. That was in 1996. And this is my retirement, is what I tell people. I'm retired now. I'm having fun. I focus on medical case management mostly. I do receive many dementia patients or Alzheimer's patients, but people come to me often because of the medical side of the need for their elderly or their loved one.
And so, Sid, how do you two of you work together?
We complement each other because I, of course, have the caregiving staff, and we have worked really very closely together with some of the cases that Maddie has presented. And like she said a minute ago, some of these clients, our cases are more complex medically. And so she brings that forte to the table, and I bring, like I said, the caregiving forte, and we've worked very well. The important thing is communication. We've found that out is essential. And we even have our caregivers reporting to Maddie directly on a shift by shift basis so that she has a very clear, because things can change. Some of our clients can change on an hourly or even a minute to minute basis. And again, this kind of gets us into the issues that we're going to be talking about, which is how to minimize the admission to hospitals. Because if you have that quick of response and communication, we can try to prevent the hospitalization at all costs. And that's basically why we have created this accommodation for both of us and the client and the family members.
It sounds to me like you guys are a powerhouse team together, because I know that a lot of families don't realize this, but especially when it comes to the medically complex, the care management or case management, whichever way you want to swing it, is so important in all of this. Even down to a missed medication can be the difference between, say, a Parkinson's patient really having a good day or a bad day, or there's just so many little things. So for the not complex and the fact that you both have care management and case management experience is so nice for families. I feel that as a nurse, I've done that whole care management thing in the past, and that is a lifeline for families, having somebody to manage that care and to be available to talk to and to really have somebody, especially if they're not, even if they're down the street, there's so much interpretation of medical language that people don't understand. If they don't have a healthcare person in their life, that a nurse in their life or a doctor, somebody who can explain things, it becomes overwhelming really fast.
Yes, it does. It truly
It doesn't, excuse me. It's also a first time for everybody. And of course, the education is essential. And that's what Maddie and I do provide, is that we're always making recommendations. We're always educating our family members and our clients because they don't know. They absolutely have no idea. And we try to avoid the pitfalls. And the healthcare system is broken. And I think the three elements that my business model is based on is the fact that there's very little transparency, there's very little communication, and there's very little family support, if at all.
Yeah.
So I pass that on, and my expectations are very high with my own caregivers. I need them to promote those three elements that are missing. And that's, I think, that's helped my reputation in the industry, is that without those three elements, bridging the gaps in healthcare, nobody else is going to be an advocate for them because they just don't know how to be an advocate.
They don't know what they don't know.
They
Yes,
don't know
and I
what they don't
think
know.
even at this stage of our careers, there is never, if the family needs us, we're the few that the two of us, whether it's Sunday afternoon, we may not want to do it, we're tired, but we will go out and make a home visit, or we will meet a patient who's being discharged from the hospital because nobody else is able to be there. And that makes a big difference, especially with the older folks whose family may be out of town, especially.
Yeah. Yep.
That's a very good point, Maddie, because I tell clients that, look, I'm available 24/7. I have a staff coordinator and supervisor who's also available 24/7. We have a weekend scheduler on the weekends. And I want to be responsive because that's what most of our clients are. I have to say this, they get overwhelmed. They get very emotional at the least little thing, but we are understanding of that. We appreciate that and we are responsive. So we basically operate as a concierge practice.
Yes.
That's lovely. That is great. It's good for people to know that because they're not going to get that level of service and individual attention from most generic home care agencies. It's just not available.
Not going to happen.
Not possible.
Correct.
That can happen, yes.
So,
And now, I'm
go
sorry.
ahead. No, go ahead.
I was going to say the hospitals are so inundated with patients that even their discharge packets are not intentionally incomplete, but they're incomplete. So I open it and I call back the nurse, whether it's a SID patient or another patient, and I say, I need more information. I have caregivers in the house. I need to know when he last ate. Did he get his medicine at noon today? Or are we starting all over again? I need a med list. And both of us have been able to create a huge resource of people we know in the medical community. And we access that. Because it's critical.
Isn't that funny how people go home and from a nurse perspective, there's no one to report off to. There's no one to give report to say, if you work in the hospital, from one shift to another, nurse to nurse, we give report to the next shift and we say, here's what's happened, here's what's going to happen, here's what needs to happen. And then, but when you go home, it's like they tell the family members, if there is any, who are not going to remember all of this probably.
That's true.
They get this folder and they go home and they are just kind of hoping that everything's going to go okay. And there's no one to give report to say, this is what you need to do now. And they're just too overwhelmed to absorb it anyway. So having folks like you to be able to call back and ask those questions is so nice. So very nice. I know that we want to talk a little bit about the current condition or status of hospital stays. So I'm going to ask you guys this question and either one of you can answer it.
Sure.
So what is the current condition or status of hospital stays today in terms of care, treatment, and hazards for the health and well-being of patients or clients being admitted and discharged from the hospital? What's going on there? What do you guys see?
What I see is most patients who are over 75 are admitted because they're concerned if they cannot find anything with the patient, they're worried they're missing something. The patient's 75 or older, they will be admitted regardless of what they think the diagnosis is. That's number one. Number two, they could be in an emergency room for 12 to 48 hours, depending on the day, the night, the day, whatever's going on in the ERs. Number three, I tell everyone, you cannot leave an elder person in the hospital without a sitter, a caregiver, or somebody from the family. It's not that they don't want to take care of him. The nurses, too, are very overwhelmed and very short-staffed.
You can't leave a 40-year-old in the hospital by themselves at this point, even if they can talk. There's
not. What did the doctor say?
I don't know.
Yeah, exactly.
I could go
He said
home.
something I don't remember. So it's a very stressful time in the healthcare, in the hospitals.
Yes.
The other thing I might mention is the health risk of being in the hospital for any period of time. And COVID was a good example of that, but even some of the other diseases or illnesses that can be contracted in the hospital, I've seen people who've gone into the hospital without pneumonia come back out with pneumonia or some other contagious illness or disease. So it's very important to try to minimize that exposure as best as you can. And again, Maddie mentioned the understaffing, which is true not just in the hospitals really, but basically in every corner of the country and really just about every facility that's providing care
Yes,
assistance.
very true.
Yeah, even in assisted living communities, we're seeing that.
Mhm.
Yeah.
But yeah, the other thing too is I got to say this because Houston is probably the medical capital of the world.
Yeah.
I don't know how many hospitals we have, and just in our medical center alone, I think there are 10 to 12 hospitals. But one of the things that I found out in the nursing home industry is that you're doing tasks. There's no time, literally no time, I know in the nursing home to have one-on-one caregiving, not even close to one-on-one caregiving, where the staffing ratios in a typical nursing home today, even on a day shift, could be in an 8-hour shift, could be 1 to 12 or 1 to
Mhm.
15.
Yeah.
That means that you may have at the most 10 minutes for each patient.
Mm-hmm.
So the same is true in the hospital setting. And that's what Maddie was discussing earlier. But they're just doing tasks, and there's no understanding of what the history of the patient is other than looking at the chart. They don't have any knowledge of the family and other conditions or circumstances that led them to the hospital. And the other problem is that the family practitioner doesn't usually go into the hospital because hospitalists are now managing the whole admission and during the time of admission. And occasionally a consult will be called on, but it's very rare. So that's where some of the breakdown in communication is.
Mm-hmm. Yeah, you don't see the primary care physician making rounds the way they used to.
No,
No,
no.
it's a hospitalist system.
Correct.
See somebody you've never met that doesn't know you,
Doesn't know.
making
Correct.
rounds and
Correct.
hoping for the best.
And
That's
they may
right.
have 27 patients on
Oh,
their
sure.
floor. Yeah.
Yeah, it's so many people to see and to round on. And what's the best way? I know the next thing we want to talk about is what is the best way to keep people from going to the hospital in the first place? What can we put in place to help avoid hospitalizations?
Education with excellent communication is, to me, is one of the keys. Teaching a family member or having them understand the importance before you call 911.
Yeah.
Make sure it's a 911 call. If your mom has a temperature, maybe call urgent care first, but don't just call 911 and go to the main hospital down in the medical center. You could be there for 3 days in the ER at times. Education with the caregivers. I like working with SIDS folks because they want to learn. They want to hear what I have to say and they follow through with it. Occasionally there's a little bit of pushback. They don't know me or whatever, but not tremendously. It takes one time explaining, hey, I'm teaching you skills you're going to use for the rest of your life. And that is critical with the caregivers. But the families are a big part of why people end up in the emergency room, in my opinion. They react, they don't think it through, and they just head on in.
They get emotional and
Yeah, and they get
they want to
tired.
make sure
Tired.
that
That's right.
no matter how significant or insignificant it might be, they're going to be very emotional, and they
Yeah.
just make have a knee-jerk reaction to taking somebody to the hospital. And like you said, particularly for people who are chronically ill, and if there's a significant change, of course, then it would be important to call their physician and let them know. And again, it's the responsiveness of the physicians because usually, and I hate to say this, but a lot of doctors on the weekends in particular, they're not available or somebody's on call. And the first answer is if this is an emergency, if they don't get anybody on the phone, then the first message that you hear is, we'll call 911. So we're
Yeah.
encouraging people to call 911 when it may not even be necessary.
It's a simple urinary tract infection that could be treated at an urgent care can make somebody act kind of wild. They can really
Yeah.
have some mental issues,
Of course.
especially as we get older, if for something that could be easily treated, but it looks scary in the moment. If you're not aware,
Sure.
you don't have the skill to assess what this could be, you don't know, then the first thought is, let's just take them to the emergency room or take them, or you're right, you call the doctor and they say, if you really think that you're not sure, or they'll give it back to the
Yeah.
family member, then you maybe need to take them to the emergency room.
And the facilities tend to do that. I mean, they're employees as well, the facility. And somebody calls and said, I don't feel good, or I'm short of breath. They may not know the patient has oxygen right there in the apartment or has pulmonary disease chronically. They're going to react, call 911. The person is over 75 and they're going to whiz them off to the emergency room.
And it's funny that you say for folks over 75, I wonder, I guess eye doctors today or the ER physicians or the hospitalists are covering all the bases so that they don't get accused of missing anything.
That's right.
So it's easier just to admit and make sure. And then
I had a patient who the first words out of her mouth when she didn't feel well was, I'm going to the ER. This was inadvertently her pattern. She'd go to the ER, they would admit her, and then the next day she'd call me and say, get me out of here. But she didn't have any children close by. And so she would just call the concierge at her apartment building, say, I need to go to the hospital. And they would call 911. And then she said, get me out of here.
Yeah, she got some attention and had some fun, but
one other thing that I think needs to be addressed is the fact that many people still don't have an advance directive.
Yes.
They haven't made a short or a long-term healthcare plan in the event that something occurs medically, and or don't even have a medical power of attorney. And they have to react to they have to react to a situation instead of being proactive. And I think it's absolutely essential that people have those documents available and ready. A lot of people don't even know what an out-of-hospital do not resuscitate is, because in some situations, which I've seen both in the nursing home and at home, is that if the family, they may have an in-hospital do not resuscitate, but they don't even know what an out-of-hospital do not resuscitate is. And once they call an ambulance, and if their wish is not to be resuscitated, as soon as the ambulance arrives and loads that patient, on the way to the hospital, if they code, they're going to do everything they can to save that patient. So that's an important document to have in some cases.
And having 10,000 copies of that document available to every adult child.
You got it. Absolutely.
And the person in the house, in the car. I can recall from having family members that we managed care for, you constantly have to be re-giving those documents to the hospital with every admission, with every change.
Yes.
The doctor doesn't have a copy, or even if the doctor has a copy, if it's 8:00 on a Sunday night, that's not available. So you have to have another copy in your hands of all those things. So
the worst case situation I had in the nursing home was, we knew that somebody had an a DNR, but couldn't locate it. And if you call 911, they're coming into the facility, they're going to do it again. They're going to try to resuscitate, even though the family knows that there should be an out-of-hospital, an in-facility DNR. So that can be very problematic, especially if you're trying to resuscitate a 95-year-old woman who's frail and elderly, And, you're going to cause more harm trying to resuscitate that individual. So it's very important that you locate the documents and they're readily available. And like you said, Valerie, that you've got a number of copies available and accessible.
Yes, everybody. I sent my family members a box, and I can't remember the name of it right now, but they sell packets and binders online and all kinds of stuff for organization of this stuff. So it's called a knock box, and it's got it's called next of kin is what knock stands for. And
Right.
it's this file folder box full, and you don't have to buy one to do this, but it's got a slot for their insurance papers, a slot for their DNR, a slot for their power of attorney. It's got all the things. It lets you organize that information, which I'm sure you've done a lot of, both of you, for
We
folks,
have.
making sure everybody knows where all those documents are. And that can save so much time and heartache, knowing where those documents are and knowing that person's wishes, and all the kids knowing the same thing at the same time.
Yes, that's
really
really critical, is knowing the person's wishes at the same time. All children should hear it, all adults.
Yes. From the person, the adult, from the mom or dad, if possible, from their mouths. This is what I want. This is what I don't want. And talking to you two, this is great. I wish every family had the opportunity to talk to some well-versed veterans in this area, because there's so many things that can be avoided, and we hate having these conversations with our parents, but everybody's going to get older, hopefully, if you're lucky, and everybody's going to pass away.
You can't put aging off.
No.
Yeah, cannot. That's exactly right. I have gone as far as had to arrange funerals for families that they didn't have any, and they had no plan.
Yeah.
And it was,
that's rough.
It's hard on them, and
it's expensive.
It's sad and it's expensive, but more important, they feel so trapped. They feel sad because they didn't recognize to do it. Not only do they have the grief of the loss of a parent, they're grieving how could they let this slip by?
It's rough. And if you've ever had someone pass away suddenly in your life at a young age, or middle age even, they're young enough that they didn't realize really quickly how important it is to put a plan in place, because having to have people who never thought they would have to make these decisions go and choose all these different things and how much to spend. I think funerals are really way more expensive than people realize.
No, that's true.
And so it's really hard. Even if your parent was older, it's hard. It's a hard moment. So having everything arranged in advance is such a good thing to do.
Yeah.
I want to thank both of you for
thank you.
sharing your wisdom with us and letting everybody know what the important things are. And Houston is very lucky to have you both. So
thank you so much.
Thank you for being on Care Across America. Thank you.